Right. Dr. Deukmedjian here at Deuk Spine Institute. And today is September 9th, I believe, 2021. And we are getting ready to perform our second surgery of the day. Our patient, he is here with back pain in his lower back and pain down the leg on the right side. He has 2 herniated discs. Did you show the audience the herniations?
Yes.
So you can see the difference at L4-5 and L5-S1. And we're going to go repair those discs. We're not doing fusion. We're not doing artificial discs. We're doing a minor procedure that's going to repair the discs that if he had gone anywhere else, the surgeons would be telling him fusion or artificial
Disc herniations are a common cause of
So
chronic
we
back
found
pain.
a place that doesn't have to do fusion or artificial discs to cure the pain. And he's awake. We're not going to mention names or anything, but are you comfortable?
The inflamed annular
All
tear
right, this is
causes
Dr.
back pain.
Deukmedjian. So we're going to keep you awake for the first 10 minutes, and then I'm going to put you to sleep, okay? Now, you may feel a little bit of discomfort from what I'm doing. If you do, just say, ouch. And then tell me, is it your back that's hurting, or is it shooting down your leg? I don't expect you to have pain down your leg, but if you do, say, ouch, down my leg. Okay? Now, are you comfortable the way you're lying? Yeah. Okay, good. All right, we're going to get started. You're going to feel a little stick as I'm putting some numbing medicine, okay? And that's my hand. I'm just feeling around for things, what I call landmarks, okay? It's kind of like when you're playing an instrument like a saxophone, you feel around for the keys. So you get your fingers on the right spot. You'll feel a little stick and a burn, and that's normal. Is that uncomfortable? Yeah. Do we use some pH stabilizer? How come we're not? Can we try? The anesthesiologist can help you. Hey, the anesthesiologist can help you. They know how to do it. Bicarbonate? Bicarbonate, the amount of bicarbonate for the injection? Just, you know, in the future for the local, I don't know how much you put in there, like 10% or something? Is it 10%? Yeah, just help them for the next one. Okie dokie. The numbing medicine is in, and we're going to give it a second to work. All right, so why don't you show everyone what we're going to be doing today? We have a animation video that shows the
Disc herniations are a common cause of chronic back pain.
You run that now while we get started. Sir, are you comfortable?
The inflamed annular tear causes back pain. Inflammation of the nerve roots causes leg pain. A Band-Aid-sized skin incision is made. A small tube is inserted without damaging the bone or soft tissues. The laser removes the herniation and debrides the annular tear. The annular tear heals on its own.
The sacrum is lined up. It looks like an ice cream cone. You can tell it's close to lunchtime because we're thinking about food. All right. So what I tell everybody is, listen, before you get going, you know, and get too far, make sure that the X-ray is in the right position, right? So for you, you want to make sure all your students in band are in their right position, right? Okay, just everything's fine. Just relax. I'll give you a little more medicine. Do you normally take pain medication? No. All right. Everything's fine, I promise. Nothing bad is going to happen. This is just part of getting down to the painful discs. And just think, you're going to get to watch all this later on. All right. So give that a minute to work. It's a good thing I've done this a couple of times, right? Do you have any of your students watching? Probably better that way anyway, right? Sean? Yeah. Sean? Yeah, I know. That's a sensitive spot. I get it. All right. Shot. So we're trying to access L5-S1. Shot. And for those of you who have not watched these before, L5-S1 is honestly the hardest to do. Shot. Because of the anatomy of the patients, the way our bodies are structured. Shot. I think I need to be a little bit more lateral. Shot. Everything's going well. Is that bothering you? All right, let me give you a little more numbing medicine. Just give it a minute to work. All right. So our trajectory looks good. Blood pressure is pretty good. Bring it down just a smidgen. Shot. Our trajectory is looking good. Shot. Yeah. Shot. Let's go AP. I was going to say, you got tall. Right? Shot. All right, good. We're just very close. Almost there. You're doing great, by the way. Just relax. We're getting to your L5-S1. This is the hardest one, okay, for you as the patient, but also for me. And we're almost done with this one. Shot. So just lay still, and we've almost got it, okay? Shot. Shot. Where do you feel that?
Deeper in the back.
Still the back?
Yes, sir.
Not down your leg?
Yes, sir.
Shot. Where?
I feel that in the back.
Let's get an AP, just to make sure. So for those of you watching the surgery, wondering, how do we do this? Well, you must have the ability to navigate. And whether you're navigating a ship in the ocean, or you're navigating, that's good, back to a lateral, or you're navigating a submarine in the ocean, or an airplane, Whenever you have a starting point and a destination, you have to have a flight path. A path that you take to get from the starting point to the destination. And for all of these surgeries, the starting point is outside here, somewhere on the skin surface or the body surface, okay? And the destination is, for these surgeries, is the annular tear where the herniation is. That's the source of pain. So I have to find a way to go from out here to there safely without hurting anything. There are a lot of vital structures like blood vessels, nerves, the spine, muscles. I've got to navigate through them without doing damage to them. Okay, that's what minimally invasive spine surgery is all about. It's about accessing or getting to this part of the body that needs to be fixed in the spine without doing any damage. And of all the surgeries available in the world, this that you're watching is the least damaging and least invasive by miles because of this technology. So, to navigate, we need a reliable system of navigation. And I can't use my iPhone maps to navigate down to his disc. I need something that's real-time, reliable. And the three things I use, I should say. Number one, the fluoroscope, which is the X-ray. Number two, the patient. Believe it or not, he helps me navigate properly by telling me if I got too close to the nerve. And number three, the feel of that needle in my hand. I can actually feel it passing through tissues, and I can make sure it's going where it's supposed to go with the feeling, okay? It's hard to imagine that a needle could be the extension of a surgeon's sensory organ, but it is. All right, so L5-S1 has been accessed. Now we're heading towards L4-5, and then we're going to put our patient to sleep. Shot? You've watched these surgeries, right?
Yeah.
How many have you watched? 2 or 3? Why only 2 or 3? You don't find them entertaining?
There's a few more things I'd like to watch.
Shot. There's other things you like to watch? What could possibly be more entertaining than my surgeries? I mean, after all, they're free, Sean. I don't charge anybody to watch the surgery, right? You get to see it for free. Sean?
Easily access DVD sign-in to see that.
You watch it through the app? Good. I'm glad to hear that. Yeah, the app is actually turning out to be quite popular among people for various reasons. Not just to watch live surgery, but also to get information about common spine conditions, Sean? Like, herniated discs or facet syndrome or spinal stenosis, whatever it is people are looking for. Sean? All right. You're doing great, by the way. Sean? Sean? I can feel the herniation. You can somewhat see it on the X-ray, even with the X-ray. Typically, you can't see herniations on the X-ray unless you have a really good X-ray machine, which we do. We have the best. Where are you from originally?
I was born in Jersey.
In New Jersey? Somebody's asking, where were you born in Jersey?
Flemington.
She knows that area. All right. That's our director of nursing. Okie dokie. You comfy? How long have you had back pain for?
Better part of a year and a half.
So let's rewind the clock 2 years. For 2 years ago, did you ever have back pain? Occasional flare-up. How many times a year?
1 to 2.
All right, 1 to 2 times a year it would flare up. For how many years did you get flare-ups? 6 years?
Yeah, I would say about 6 years ago. Yeah.
Did you remember when you hurt your back?
Lifting a piano.
Lifting a piano. And that was about 6 years ago?
Yeah, I've got it.
All right. Well, you have shared quite a bit of history that's very helpful. Obviously, lifting the piano caused the herniation, and the jelly in the center of your disc, the nucleus, pushed through the annular tear, and then you would get intermittent flare-ups as you aggravated the tear and got inflammation going, okay? And now the pains become pretty much constant, right? Yeah. So here you are entrusting Deuk Spine Institute to fix your back, and that's exactly what we're going to do for you. Just don't lift any more pianos for a while, okay? All right. So we know from your MRI the L5-S1 disc, and you're going to appreciate this when you wake up and watch your surgery. This is the L5-S1 disc. There's a tear, and L5 to S1. S is the sacrum. That's the L5-S1 disc. And then we're also see a tear and herniation at L4-5. Okay? L4. Sorry, I'm not left-handed, but I'm writing left-handed. All right, so we have two discs that are torn and herniated, and that's where his back pain's coming from. You know, before I discovered this, nobody really knew that the tears and herniations caused back pain or neck pain. As a matter of fact, most doctors don't know that. Are you comfy? Yeah. Good. Ow. How bad is that on a scale of 1 to 10? 8. You knew that was coming, right? No. Yeah, you did. What's the highest it went?
8. Yeah.
Is that where you typically get your back pain?
The back pain was a little, yes, and then down the leg, that's pain.
Yeah. All right, so that L5-S1 is an 8 out of 10, and it's concordant. Okay. See, if you had watched more of my surgeries, you would have known that was going to happen. Okay. I apologize. We had to do the discogram to test the disc to make sure it's a painful disc for you. Definitely was. How bad is that on a scale of 1 to 10? Don't be a brave.
7.
All right. So a 7 out of 10? Is that where you typically get your back pain?
Typically towards the lower part.
Yeah. All right. Well, that is your lower back. Guess what? You get to go to sleep now. And when you wake up, your surgery will be over and that pain will be gone. That's the good news. So I want you to count from 1 to 100 in New Jersey. What do people speak in New Jersey? All right. All right, count out loud for me, 1 to 100. So while he's counting and going off to sleep, counting sheep going off to sleep, our anesthesiologist is now giving him an injection of propofol. You feel a little burning in your arm. That's normal. It's the propofol. So he is being put to sleep through what's called IV anesthesia, intravenous anesthesia, as opposed to a gas anesthesia. We don't use gas anesthesia for these surgeries because for gas anesthesia you have to have a tube down there into their lung and on a ventilator. And it's unnecessary. That's way too aggressive for what we're doing. So he's twilight anesthesia, and he'll sleep through the surgery and wake up when we want him to, when we stop giving him the propofol shot. And at that point, he will be done with his surgery. We'll put a Band-Aid shot, and we'll be done. Is he out? All right. So we've made a 7-millimeter incision here, and the whole surgery will be done through this 1/4-inch incision. Okay? Next goes the dilator. And again, we're going to go right past the facet joint. That's where the tip is now. Want to make sure your guide wire doesn't advance accidentally. Sometimes it can get pinched between the tip of the dilator and the guide wire shot. So I'm gently, carefully advancing it through the foramen, underneath the nerve root that's coming out. That's going to be your L5 nerve root. And now we're where the herniation is. And I want to advance this along the guide wire. I know that the guide wire is safe. As long as this follows the guide wire, which it will, because the guide wire runs through it, as long as the dilator follows the guide wire, we know that we're not going to hurt him by doing any damage. There are people who, believe it or not, do the surgery without the guide wire, and I think they're just crazy. And they hurt people. So you got to watch out for crazy surgeons. Okay, so we're advancing the tip of the dilator into the disc space. Shot. Through what's called the annular tear or tear in the annulus fibrosus. That's the source of the herniation. Did you run the video?
Yes, I did.
So do they know what an annular tear is?
They do.
Take that.
Do you have time for questions?
No, not right now. Now I do.
Okay, cool. So our first question comes from Facebook.
Hold on. Just before I take the question, let me just orient everyone. Folks, the Deuk laser disc repair surgery you're watching right now is a 2-level L4-5, L5S1 right side, because his leg pain is down the right leg. So we know the herniation is on the right side, irritating the nerve roots going down the right leg. That would be the L4, L5S1 nerve roots. And we're going to go in there and clean up the herniation with a laser, remove it, and clean up the annular tear through a debridement. And that should take care of the back pain and the leg pain permanently. And we're doing the entire surgery through this tube. It looks like a milkshake straw that's metal, but it's actually the tubular retractor that we're doing the whole surgery. It's going to slide over the dilator. Okay? Why do we broadcast our surgeries live? So you can ask questions, but also so you can see the whole surgery. We're not hiding anything. And I've broadcast every single surgery we've done here in the last 10 years. In this surgery center, we broadcast live. And we've recorded. So we give a copy of it to our patients so they can watch it. And of course, they have their families watching and friends. Everybody that wants to watch, that's invited to watch, can watch. Shot. All right, so look what happened there. The dilator advanced with the tube. We don't want that. And the reason that happens is because there's a little bit of tissue, a little bit of the herniation that gets wedged. It gets wedged in there. And that's what's happened. Shot. And it's still wedged in there. I need to stabilize the tube, the outer tube, Luis. That's the problem. We need to hold the tube in place and not let it come out because it's pinched at the end. So you get to see how we troubleshoot. Tell me when you're ready.
I'm ready.
Oh, perfect. Let's see what we got. All right. So I think we need to be, we're just about there with the tube. I think we can advance both a little bit. Let's see, maybe I'll just try to advance the tube like this. Shot. All right, let's try that. So what we've done here is I've advanced both the dilator and the tube rather than just the tube into the disc space, and now I'm pulling the dilator out, and you can see what's being left behind is the tube. And that's what we want. We want to leave the tube behind inside the disc, and we want to fix the disc while we're there. You can come off. Shot. And as I'm taking my dilator out, I'm checking my tube to make sure that we're in good position. Fluoro out. we're going to remove this fluoro unit, which is an x-ray machine, and I'm going to try to fix the L5-S1 disc. Okay. So attach the fluid, what's called a fluid adapter, and I line up, there's a little mark on the tube that tells me where the opening, because the end of the tube is what's called fenestrated. It means it has an aperture that is more open on one side than the other, and you're supposed to put that at 12 o'clock at the median side where the midline is. Okay, you want to get my wrist?
Yes, sir.
We're going to start, what? I don't know what you're saying. It's fine. No, I would tell you if you need to move it. Yeah.
Jeremy, step out just so you know.
Huh?
Jeremy, step out just so you know.
Everything okay?
You have a doctor's appointment.
Okay. All right. So we're inside the disc. And again, the blue is the stain that we use
Lights off, please.
to stain the degenerated nucleus pulposus. Tick, tick, tick. And if you look, you can see that there's a little bit blurry, so I'm going to try to improve the focus. There, that's better. Okay? What you're looking at is the annular tear. And that's what we're here to fix. L5-S1 is the hardest disc to fix with endoscopic transforaminal surgery. There are endoscopic surgeons around the world, in Korea, China, Germany, other countries, that see the scar tissue right there? That's what it looks like. This is all.
Hey, what's going on?
We just lost our light. Mm-hmm.
Disc herniations are a common cause of chronic back pain. The inflamed annular tear causes back pain. Inflammation of the nerve roots causes leg pain. A Band-Aid-sized skin incision is made. A small tube is inserted without damaging the bone or soft tissues. The laser removes the herniation and debrides the annular tear. The annular tear heals on its own. If you have a herniated or bulging disc and back pain, submit your MRI for a free review at www.mri.deukspine.com. Traumatic injury to the disc can cause annular tears to form. Pressure on the disc causes herniation of the nucleus pulpus through the annular tear. Inflammatory tissues develop. Traumatic injury to the disc can cause annular tears to form. Pressure on the disc causes herniation of the nucleus pulpus through the annular tear. Inflammatory tissues develop within the annular tear, causing back pain. The inflamed annular tear generates pain signals. Additional injuries can cause symptoms to worsen. Inflammation from the annular tear can spread to nearby nerve roots, causing leg pain. signals travel up nerves to the brain, causing localized back pain. Pain signals reach the primary somatosensory cortex, causing conscious awareness of pain. If you have a herniated or bulging disc and back pain, submit your MRI for a free review at www.mri.deukspine.com. Traumatic injury to the disc can cause annular tears to form. Pressure on the disc causes herniation of the nucleus
When they're
pulpus
watching a
through the
video, can they
annular
actually
tear.
hear me?
No, because I muted you.
Then just let me know when that happens so I don't just keep talking
Gotcha.
to myself.
Well, you're live now.
Okay, we're back. For those of you who were watching, our light bulb burned out. So our light bulb is part of the endoscopic system. It's in a box, a computer box, and the bulb just shut down. So now we've switched to another light bulb and another box, and we're back online. I need you to go back to the laser. And all right, thank you. Take your time, we're gonna get started. I'm gonna go back to the laser. So one of the reasons we do live surgery is so you can watch surgeries being done. And you know, our goal here is to teach people about reality, not the fake world that you're used to seeing in movies and edited programs. We want people to see what really happens in the operating room. Why? I'll be honest with you, I don't have a lot of faith in our medical education system. Careful now, just leave it there. Pull it back further if you want. And I think the quality of education is deteriorated in our country and around the world. And so why do we want to capture my surgeries? Because the way that surgery has been taught for centuries to surgeons is from one surgeon teaching another by talking to them and showing them in real time. But never has there existed a comprehensive archive of live surgeries that is as extensive as what we're producing at Deuk Spine Institute. We have literally over 1,000 surgeries, whether they're open surgery fusions, cervical fusion, anterior cervical discectomy and fusion, posterior cervical laminectomy, posterior cervical fusion with instrumentation, lateral mass screw placement, rods, reconstructions, osteotomies, discectomy, interbody fusion, interbody devices, spinal cord stimulator, carpal tunnel syndrome. Whatever we do, whatever I do surgically, I capture in high definition with our multimedia system that is amazing, with the eye in the sky and a first-person view, and x-ray and endoscopy and fluoroscopy and microscopy, whatever media I'm using. And we have that entire surgery archived for future generations of surgeons to watch and learn from, honestly, the best technique available today in 2021. And every year, you know, there are new technologies, and if we incorporate them in our treatment, then we have those as well. The important point is that I feel that the surgeons of tomorrow in spine surgery are not going to get the same level of education and training to take care of patients at the academic institutions where they're training now, because the academic centers are completely biased and corrupted. Yes, it's true. Why don't you share, Diego, with our audience what we just saw on the news yesterday? One of these systems of corruption. So you wonder, why doesn't the Deuk laser disc repair get done everywhere? Why are people still doing spine fusions? I'm going to show you why. The federal government just indicted a neurosurgeon, Kingsley Chin, who is the owner of Spinal Frontiers. They basically sell screws and rods and plates for fusions and basically devices for the spine. And they've been paying kickbacks to spine surgeons for years. And these surgeons they're getting kickbacks are putting in their screws and rods in people's spines and recommending fusions. Okay? And they're getting money for doing that. They're getting millions of dollars. They've literally got in trouble. They just got indicted, and they're going to go be sued, and they're going to go to court, and these people are going to go to jail, basically, but it's criminal activity, which is giving surgeons kickbacks for putting screws and rods in patients. And that's what people are up against. The surgeons you trust, the ones in your community where you live that recommending fusions or artificial discs, they are being paid off. Okay? Not all of them, but probably around at least 50% of them. And the government is after these people. These are bad players. They're recommending treatments based on rewards they're getting that they're not supposed to be getting, financial incentives. Okay? And it's come out in the news. So Diego, you want to share that article? Do you have it?
Yeah, it's being shared currently.
All right, there it is. Okay, I don't make this stuff up. I talk about it, but I don't make it up. Why do we talk about it? Because this program is about transparency in medicine. We're all about showing the truth. Okay? For example, we just had one of our lights burn out, and we had to change the light source. Luis did an amazing job. He was on it. And we switched over to a new light machine for the endoscope, and now we're back operational again. But it's all about being prepared. It's about making the right diagnosis and being prepared. So we made the diagnosis. What was the diagnosis, Luis? The light burnout. Okay? And we were prepared for a treatment. The treatment was switch the light source. Okay? Now, if we didn't have another light source, guess what? This patient with surgery would have to be ended, and we wouldn't be able to finish it. So by having another light source, we're able to carry on. But you got to see what happened. So in the future, surgeons will be better prepared for their patients long after I'm dead and buried, because they watch my videos and they realize, my God, we need to have a second light source ready to go. Okay? So it's called redundancy. This is all scar tissue, by the way, from his disc herniation. This is not normal annulus. This is totally scarred up, fibrosed. Fibrosis means scarring. This is a fibrosed disc from the original injury, which happened 6 years ago when he was lifting a piano. Okay? And because of that injury, he now has been suffering for the last year and a half with daily constant back pain from the herniated disc. Who diagnosed it? Deuk Spine. Who's fixing it? Deuk Spine Institute is. So why is that important? Because I go to Facebook every day and I deal with people on Facebook in these support groups, and it's amazing how many people have no clue that their back pain and neck pain is curable. And we cure this stuff every week with our surgeries. Now the problem is there are very few surgeons who know how to cure back and neck pain, like literally less than 1% do. So most of what the people are hearing out there is that it's not curable. And that was true for the last 100 years. We never were able to cure back and neck pain. See the blurriness there? You see how it gets a little blurry? I think that, I don't know, maybe that's some of the dye, but my concern is that it's the lens. All right, there's our tear, and we're going to clean it up. This is the debridement that we do here at Deuk Spine. You won't get this treatment anywhere else in the world, folks. That's because we pioneered the cure to back and neck pain right here at Deuk Spine Institute in Orlando, Florida. And this is where you need to come to get this treatment. This is all abnormal tissue in the annulus from the disc herniation that's been there for 6 years or longer. Could have been even older. Look at that herniation. Right. That's the interposed nucleus right there that I'm getting with the laser. Look at it. All scarred up from chronic inflammation. Makes perfect sense. So if you're suffering with back pain and you want to get rid of it, this is the procedure you do to get rid of your back pain. If you have neck pain, we can do the same thing in your neck. If you have thoracic pain, well, for the last year and a half, we've been doing thoracic herniations as well. And we've had 0 complications to date. How is our patient, doctor? All right. This is taking a while because of all the scar tissue, which you can't really see on the MRI. Stand by. See how ineffective these grabbers are? They don't really fix the problem. All that traditional instruments can do is pull out pieces of herniation that I've already freed up with the laser. But the key is you really do need the laser. You need the laser to free up the pieces. And once you free up the pieces, then you can remove them with traditional instruments. That these instruments don't work unless you've released the herniations already, because they're scarred down. The herniations are scarred from inflammation or fibrosis of the disc, from the tear. Diego, have you shown our audience the Deuk laser disc repair animation?
Yes, I started it off
You
with
showed
that.
the cause of the back pain and you showed the hernia Deuk laser disc repair.
Yes.
All right, well, good. We created those animations, folks, because we're the ones who discovered the annular tear as a source of back pain, and we have one for the neck as well. Any questions from our audience? There's a piece of herniated disc right there.
Yes, we have a question from Facebook. Can physical therapy do more damage to a herniated disc?
Can physical therapy do more damage to a herniated disc? Yes. Physical therapy never fixes a herniated disc that causes pain. Never. Okay, what physical therapy does that is so important is it keeps you from letting your muscles and joints just sit there and atrophy. Atrophy means like when you don't use a muscle or joint, it gets just withers away. I think that's the best way to say it. So therapy is very important, okay? It won't fix your pain from your herniated disc at all. But what therapy does is it buys you time to let your disc heal on its own when you have a herniated disc that hurts. Remember, most herniated discs heal themselves, okay? They never go back to normal, but they heal to the point where the pain goes away most of the time. About 90, probably 95% of herniated discs heal themselves. And therapy is important because it keeps your muscles toned and fit and keeps you from developing atrophy and deconditioning, okay? But the therapist has to be careful not to injure your herniation and make it worse, aggravate it. But they can. I've seen them do it. So you got to go to a good therapist. Good therapists are hard to come by. You know, you got to find somebody who you trust. I've had many therapists that my patients went to because they don't live where we are. You know, people fly in from all over the world to have this laser surgery we're doing because it's not offered anywhere else in the world. And when they go home and they do therapy, many of them are doing therapy that we don't supervise directly, so the therapist could do something to hurt them. That's why we give our patients very specific instructions about follow up with Dr. Schrumpf, the head of therapy, make sure you're not doing anything wrong. Look at this just massive amount of scar tissue from this disc. There's the tear, there's the end of the tear. Look at the granulation stuff in there, the pink tissue. That's where all the painful nerves are. That's what we're cleaning out right now. Hopefully the animation has explained how this works, but basically it all starts with trauma to your disc where you get a tear in the annulus fibrosus.
Disc herniations are a common cause of chronic back pain.
Blue jelly in. Once that tear happens, now the blue jelly can squeeze out. And once the blue jelly squeezes out, look at this scar tissue. This is a giant wad of scar tissue. I need a chair. Hi, Monica. Yeah. A chair. I'm gonna be here for a little while. Thanks. How many people have ever seen a surgeon sit down? That's fine. It's a little short, but you know, who am I to complain? Sometimes musicians have to sit down. Sometimes surgeons have to sit down. I remember the first time I saw a surgeon sit down during surgery. I couldn't believe my eyes. I was in surgery with them and they sat down. I'm like, what? I didn't know you can sit down during surgery. That's pretty cool. And yeah, we do. I mean, some of the neurosurgeries that we do, you know, especially brain surgery, can take 4, 5, 6, 8 hours, 10 hours. So you sort of need to take a break while you're operating and just sit down for a little bit. Otherwise you get too tired. All right. Things are going good. Little nest of granulation tissue there.
We have a new question from Facebook.
You have a question.
Yes. Can aggravated nerves in the back cause
I need
problems?
you to pump your volume up.
Okay.
Pump up the volume, please.
Is this better?
Not much.
How about now?
Yes.
Okay. Can aggravated nerves in the back cause problems in the stomach?
Can aggravated nerves in the back cause problems in the stomach?
Yes.
No. They cannot. I don't know what kind of stomach problems you're referring to, but I imagine you're talking about like stomach ache or diarrhea or constipation. I imagine, but I don't know what stomach problems you're talking about. But no, aggravated nerves in the back don't cause stomach ache or diarrhea or nausea and vomiting directly. They don't. Good question. Now the treatment of aggravated nerves with narcotic painkillers can. The narcotic opioids can actually mess with your stomach pretty bad. Anti-inflammatories can mess with your stomach. So by treating your pain and your aggravated nerves with medicines that irritate your stomach can definitely cause diarrhea, constipation. Just depends on what medicine and how much you're taking, how long you've been taking it. That's why medicines are not a good option, folks, for treating chronic back pain, because they don't work, first of all, and second of all, they have massive side effects. Okay? Anti-inflammatories. What do anti-inflammatories do that are bad? Well, number one, they're going to thin your blood. They're going to make you bleed. And they also cause ulceration in your stomach lining, so you get ulcers in your stomach. Now you combine a stomach ulcer, and what's an ulcer? An ulcer is an area in the stomach where the lining of the stomach has been eaten away by acid. Okay? And when it gets eaten away, it exposes the small blood vessels just underneath the lining of the stomach, and they get eaten away too. So if you ever watch that movie Aliens, remember Aliens? Remember when the alien blood leaked onto the metal of the ship and it ate a hole through it like 3 decks? You guys know what I'm talking about? Hey, that's what anti-inflammatories do to your stomach. They eat through your stomach wall, and they eat into the blood vessels inside your stomach wall. And then you combine that with the blood thinning properties of anti-inflammatories, where they have an effect on platelets and they prevent the platelet plug from forming. Now you have an anti-platelet effect combined with a erosion of the stomach wall effect into the blood vessels. Now you've got a bleeding source combined with a inability of your body to make blood clots. Really the platelet plug. But the platelet plug is the first step in blood clots. Okay, it's platelets that circulate looking for a area in the blood vessel that's leaking blood. And the platelets come together and make a little patch. And that patch of platelets then triggers coagulation of your blood clotting factors, okay? So if you don't make an effective platelet plug, you can bleed to death. And that's why people take aspirin to prevent a blood clot from forming in their blood vessels of their heart. But people who take anti-inflammatory pain meds for their back are basically destroying their stomach, creating ulcers, and then not being able to stop the bleeding from the ulcers. So they come to the hospital dying from bleeding ulcers in their stomach, okay? So if you think taking ibuprofen, Motrin, Aleve, Naproxen, BC powder, Goody powder, naproxen, any of those pills chronically for back pain or neck pain is a good idea, it is not. You know, take it maybe for a few days, but get your problem fixed. All right? Don't take anti-inflammatories long term. Narcotics. Should you take narcotics long term? No. They're even worse. You're addicted, you can't function, you end up on heroin on the streets, okay? You think I'm joking? Where do you think, laser please, where do you think all the heroin addicts from the 80s and 90s came from? They were all OxyContin patients who, you know, couldn't afford the OxyContin anymore and just started, they couldn't hold a job because they were in pain all the time. And now they're on the streets looking for heroin because heroin is a lot cheaper than OxyContin pills. Unfortunately, doctors created that dependency by not treating these people properly. How do you treat back pain properly? You're watching it right now. This is it. This is the surgery of the future. 20 years from now, 30 years from now, maybe even 40, depends on how arrogant and freaking thick-headed surgeons are. Until they adopt this technology that I've created, we're going to be doing all kinds of bad treatments to people. That's why I've given up on surgeons. I don't bother teaching them anymore because they're too stubborn. But you know what? The people who suffer with this condition are the ones who should care the most. That's patients suffering. That's why we reach out to them. We want people that suffer with back and neck pain to know what's going on and what's available to fix it.
Please believe me, please.
That's one of the reasons we broadcast. Surgeons do bad things. They're pretty selfish for the most part. Don't expect them to put you first as a patient. They put themselves first, and that's obvious from that article that we just showed you. Came out yesterday where the federal government is indicting a bunch of surgeons for basically getting kickbacks to put screws and rods in patients. And you wonder why there's not more people that adopt this endoscopic technology. Well, you tell me when you see me put a screw in, okay?
You're crazy.
You're not going to, because we don't put any screws in. This is an all-natural healing of the disc. We're just setting the disc up to heal. The disc wants to heal. It's kind of like having a thorn in your finger. The finger won't heal until you get rid of the thorn. This herniation right here and the annulus tear is like that piece of thorn, that piece of wood. And it's not going to heal until we get rid of it. There's the nerve right there. Look at that white thing. See that? Normally we don't see it that good, but that is the, what disc are we at, 5-1? That's the L5 nerve root on the right side. Pretty cool, huh? That's the dura covering around it. So we are a little bit of fat there. Pretty much done here at L5S1. And the nerve is completely unpinched. You can see we're below the nerve. This is just the most amazing surgery in the world. I used to treat all these patients with fusions. You know? Every one of them. I don't need it. We're done. And God, they're just the whole cutting through, you know, taking the spinous process out, all the bones and ligaments out of the spine that you don't need to take. Oh, I still need to see what I'm doing. Yeah, thanks. Okay, perfect. Scope off. And we're going to put a little antiseptic, some NASA created betadine. Ooh, Louise. I love it. I love it. Look at that. Nice. That's beautiful. Luis just demonstrated what's called evolution. But you know what? I didn't get it all. I'm sorry. You know what would be good? No, we're good. We're good. If I could squirt it down there, that would be good. All right. So we're done at L5-S1. We saw the nerve. It's totally decompressed. I'm going to take this tube out. Okay. And then we'll just have one more to fix. So what I was saying earlier is all these patients, they used to come to me to get rid of their pain in their back and neck, and I used to just fuse them because I didn't know about this surgery until I heard about it. And when I first saw it, I didn't believe it, you know. But it wasn't this exact surgery. It was similar, just for unpinching the nerve to treat sciatica. And that's what some surgeons were doing. So I went and trained with Dr. Young over in Phoenix and picked up a lot of good pearls, you know, to do the surgery. But everybody was doing it for sciatica, leg pain, leg pain, leg pain. You know, radiculopathy, which is weakness, numbness, tingling in the leg. Okay, what's the problem, guys? You need to no. Before we do that, this is our only light left. All right, you want to shut it down? Turn it off. Yep. All right, unplug it. Uh-huh. Yep. And now move it back carefully, because that's our only other one we got. Do you know how to change the light bulb? Yeah. Yeah, no worries. Use these discs, and the results are amazing. I would get elimination of back pain with my fusion technique, but the patients would be in horrible pain for months, usually weeks if not months after surgery, okay, from the surgery itself. Not from the fusion. It's not the metal screws, rods, and the cages that actually cause pain. It was opening the back up and moving all those muscles over. That's what hurts so bad. And so by eliminating what's called the exposure, which is the part where you make the big cut and you move the muscles over, and you can watch it if you watch my TLIF surgery. We'll go ahead and post another TLIF link. TLIF stands for lumbar fusion. It's a transforaminal lumbar interbody fusion. And again, it's not the screws and rods that cause pain. It's actually the incision and moving the muscles over and taking the bones and ligament out of the spine. And we avoid all of that with this type of surgery. Hold on, are we in? That's us? Okay. All right. So, you know, for about, probably for about 12 years, 13 years, I was just doing both, you know, fusions and lasers, Deuk laser disc repair like you're watching now. And in the last couple of years, just people don't want fusions anymore. They just want laser surgery, and I don't blame them. So we still do fusions when we need to, when that's what somebody wants or that's what they're able to do based on their insurance. But most people don't want fusion, and I don't blame them. Much worse. All right, shot. Our patient is still quietly sleeping, very comfortable, and we're going to be done with his surgery in 15 minutes. So I'm just heading down to the last disc. This is the L4-5 disc. I can feel the herniation. Thank you. And we're going to enter the disc itself. Now he has an amazing pain tolerance because when I did his discogram, I think, what do we say, 8 and 7 or something like that? 8 and 7 out of 10. So, shot. But I'm really happy for him that he's going to get out of pain. Let me see. Shot? All right. So, yes, you have a question? I hear you shuffling. We were talking before surgery, the patient and I, about going back to work. And people all want to know, when can I go back to work? When can I go back to doing things? And the reality is that you could, you know, some jobs you can go back the next day. I'm okay. The next day. I even had one person go back to work the same day. As a matter of fact, my patient here will get a kick out of this, watching this video. Like, we're going to give him a copy of his surgery tomorrow. And the person who went back to work the same day works at the same place this person does. What? Yeah. And that person was the head coach of basketball. But I don't even know if these guys know each other. I never thought of it. So, but they're both from the same place. And yeah, the basketball coach was the head coach of the men's basketball team, and they had a championship game in Orlando the same day as his surgery. He didn't want to cancel the surgery, so he had his laser done on his back and recovered for a few hours, and then went and coached the men's basketball game. Okay? So that's how amazing this surgery is. And he had no pain. His pain was gone. This was a couple of years ago. Forgotten about that. But I wonder if they know each other. I don't know. But life is interesting, and the world is a small place, isn't it? All right. So we're getting ready to do the second disc. You remember that one? You were here. That was pretty cool. Unfortunately, they didn't win the game. But I don't know, can't blame the coach. So you can't blame me. Because if anything, I helped them, but they I know they didn't win, unfortunately. I would have liked for them to have won. All right. We're back with you for the second disc. This is L4-5. We've already finished the hardest one, L5S1. Let me just get the laser in here. So yeah, I think it's time for another light source. It may not be the bulb, that's the only issue. And we're talking about running a second room. I don't want to have to wheel everything around one room to the other. So I think, so by the way, this right here that we're getting is like less scarred than normal. There's a little piece of scarred, just to give you an idea. Look at how quickly things respond to the laser and they get zapped away when it's not scarred. That's herniation right there. It's just blasting away. Like one blast knocks it out, takes care of it. Just gets rid of the tissue, one blast. But with scar tissue, you saw, you got to hit it and hit it and hit it and hit it. So this is all blown out disc right here, just totally damaged, herniated, stained dark blue. Why? Because it's degenerated. Normal disc, nucleus in the disc does not stain blue. It's white. So the stuff we're seeing here is all degenerated nucleus pulposus. And why? It's degenerated because of the effect of inflammation on the nucleus pulposus. If there was no inflammation, then there would be no blue and there would be no degenerated disc. If you could stop inflammation completely, you could stop the inflammatory response in the disc to the injury. You could stop the pain, okay? But the problem is inflammation is necessary, part of our everyday life. We need inflammation to heal. If you have no inflammation in your body, you cannot heal any of your wounds. You will die from non-healed wounds. Bacteria would invade your body and destroy you very quickly. You all heard about flesh-eating bacteria, right? Staphylococcus. Well, that bacteria has a way of inhibiting our inflammatory system and basically going like an undetected invader in your body until it's too late and it's done tremendous damage. Oh, look at all that herniation there. This is kind of a blown out disc, unfortunately, but it's still a viable disc and it's still good and it'll last him the rest of his life, no problem, as long as we repair it. And that's what we're doing. So he won't be getting a fusion, he won't be getting an artificial disc. He just needs this repair, and he knows what his instructions are. As long as he follows my instructions carefully, he will be fine. Just like thousands of patients, thousands of discs that I've treated, okay, with the same surgery. All right, we need another 8 minutes, 10 minutes max, and we'll be done. All right, we're gonna work our way up to the outer tear. There's the tear right there. You see the tear? Right there. This white thing is one side of the annulus. There's the other side, and there's the tear and the herniation in between. And that's what we're debriding, is the annular tear. Again, the only surgery in the world that debrides the annular tear. You're watching it right now. Deuk laser disc repair. We're the first ones to publish it in the world. And the only ones doing it currently. And there's no metal, no fusion. No, we don't even do this at the hospital, folks. This is outpatient. This patient's going to go home in an hour from his surgery, where his wife will take care of him, and he can make a nice recovery at home. By tomorrow, he should be up walking around normal, without the pain that he normally had in his back or leg. How do I know? I've done thousands of these, and every single time it's exactly the same way. That's how predictable it is. But you have to treat every disc. You can't just treat one. If a patient has 2 herniated discs that are causing their pain, and you only treat one, then they're still going to have the other one causing their pain. So it's important that you get them all if you want to get rid of all the pain. Now, I will admit some disc herniations are more painful than others. You know, it's kind of hard to tell for sure which one's which, but usually I can use my experience of treating this. I could actually pick the worst one, and we could just do one if we had to, but I always recommend people get them all fixed while you can. Otherwise, you're still going to have some residual pain. I'm a believer in fixing all of them at one time, but some people want to wait, they want to do separate, and that's fine. And when I say all of them at the same time, I mean all the lumbar at the same time, not spacing the lumbars out. Lumbar is lower back, for those of you who don't know. You do the cervicals all at the same time if somebody has more than one cervical disc herniation. All right, any questions from our audience?
Yes, we have a comment from Facebook. Can you do this type of surgery on a patient that also has disc degenerative disease?
Yes, great question. So one of our Facebook viewers is saying, hey, what if someone has degenerative disc disease? By the way, this is degenerative disc disease, okay? Degenerative disc disease, there is no magical threshold. It literally starts with a herniation. That is the beginning of all degenerative disc disease. And if you want to rewind the clock a little bit more, truly degenerative disc disease starts with the annular tear. So an annular tear is the first step in all disc problems, whether it's a bulge, a herniation, degenerative disc disease, slip disc, ruptured disc, extruded disc, prolapse disc. You pick the name, it's all from the same thing. An annular tear is step number 1. So yes, this is degenerative disc disease. It's just not advanced. It's early. Okay? He still has a lot of disc material left. Look at all this scar tissue. Look how it responds very differently to the laser. It just doesn't vaporize like it did earlier, because this is really thick stuff. It's dense. It just takes a lot more energy to blast it away. All right? So this needs to be removed. This is part of the problem. This is the annulus trying to heal itself, and it just is unable to do so because there's too much of this blue stuff stuck in there, the nucleus pulposus. All right, I hope I answered your question, but the answer is yes. 100% degenerative disc disease can be fixed with this surgery.
And they say thank you.
Oh, you're welcome. You're welcome. We do it all the time. It's amazing. Like that last patient we did, the first one, if you go back and watch the first surgery today, that guy had totally degenerative disc disease. His discs were 80% collapsed from degenerative disc disease. And I don't know if you're able to show them that footage or that picture that you had of that surgery in the beginning, but that we fixed that guy. So he's doing great. I'm gonna go see if we can, after I'm done here in the next 5 minutes, I'm gonna go check on him and we're gonna let him go home. Well, not home because he's from Alabama, but I think he's living in Alabama now. All right, just about done. It's pretty cool, huh? The blue, it looks like ice. Jeez, bad tear. You know, how did I discover this surgery? Well, it's an interesting question. So I started doing endoscopic surgery like other endoscopic spine surgeons, and there's not many of them, but it was for leg pain and sciatica, basically pain down the leg. So I started doing the surgery, and I noticed that, I use the laser to do it, but other surgeons don't really use the laser. They use just grabbers, which don't work very well. Anyway, I started using the laser, and I found the laser was so effective at cleaning things up. And I realized that my patients who had sciatica, I would see them after the surgery, and I said, do you still have sciatica? No, it's gone. Really? Yeah, and my back pain's gone. Really? Your back pain's gone too? Yes. They would tell me their back pain was gone. And I'm like, really? So we got rid of your sciatica and your back pain? Well, and then I started thinking, well, what am I doing that could be getting rid of the back pain? And of course it dawned on me what I was doing was I was debriding the annular tear. And that's why we decided to publish our results in 2012 of the surgery. That was almost 10 years ago. Yeah, about 10 years ago I put it all together and submitted it to a very prestigious surgery journal, neurosurgery journal called Surgical Neurology International. And after an extensive review, peer review process, they approved it, which, you know, getting papers published these days is very hard. It really requires, obviously, good science, good data, good analysis. Try to be as unbiased as possible, but my work was published, and it still is, and it'll always be forever in the National Library of Medicine and for future generations to see. But the problem is those papers don't explain how we do it. They explain it in words, but the video is like, they say a picture paints 1,000 words, right? Well, what does a video like this for an hour paint? 1 trillion words. So there's no explaining it in paper. The old days, this is much better actually doing a video because people can really see what's going on. All right. Any more questions?
Yes, doctor. We have a comment from YouTube. Someone is asking, where is the spine cord?
Where is the spinal cord?
Yes.
Whose? Just kidding. So the spinal cord is inside the spine. The spine is really bones, ligaments, discs. We're operating on one of those discs right now. But the spine and the spinal cord are two different things. The spinal cord is a bundle of nerves. It's as thick as your pinky, and it runs in the middle of the spine. But it doesn't run the full length of the spine. It runs until what's called L1. It runs down from your brain to L1. Okay? L1 vertebrae. We are way below the L1 vertebrae. There is no spinal cord down here. This is why orthopedic surgeons who are not trained by any means to treat spinal cord problems, that's why they do so much back surgery, is because they're, hey, lay still, we're almost done. It's because there's no spinal cord down here in your lower back. So they're allowed to work down here, whereas neurosurgeons are the only ones really allowed to work on the spinal cord or near the spinal cord. So that's in, the spinal cord's in your neck and it's in your thoracic, your mid-back basically. But it's not down here. So we're nowhere near the spinal cord. So there won't be any kind of damage or injury expected from this type of surgery. Now it can happen. Okay, how can it happen? Well, I mean, your spinal cord needs blood flow, and if something compromises the blood flow to the spinal cord during surgery, it could infarct. Infarction means die from not enough blood flow. So it's certainly possible, though I've never seen it happen, and we shouldn't talk about it anymore, because I don't want to jinx anything. It's a lovely man and his wife, and I want everything to go perfect. I'm not superstitious, but you never know. Just trying to go lateral here. You can see the blue from the lateral tear that I'm debriding now. Now this tear may seem big to you, right? It looks big. Like, oh my gosh, that's huge. How is it going to heal? Very easily. It's not that big. Okay, here's why. This scope that you're looking through with me magnifies everything. It makes it look bigger than it really is. There's the end of the tear and the end of the disc right there. Goodbye, demon. So just for perspective, you see the metal tube that I'm working in, right? Side to side. That's 6 millimeters. 6 millimeters is, remember that incision I made? That was about 7 or 8 millimeters on the skin. So this is narrower than that. It's not a big space. It's about the width of a pea, a little green pea that you would eat, like a pea in a pod. That's about how wide it is. So it heals. I mean, we've all had things heal that were much bigger than a pea. You know, cuts on our body, bruises, lesions. So it can heal quite easily as long as you give it the right environment to heal, which means don't re-injure the disc while you're healing. Has that ever happened? Absolutely. 1% of my patients re-herniate their disc. That's 1 out of every 100 will do something to tear or re-injure, re-herniate, basically. And it always has to do with lifting or bending at the waist. So lifting something heavy too soon, or bending over to pick things up when they shouldn't. All right.
We have a Facebook comment. What is the fuzzy stuff?
What is the what?
Fuzzy stuff.
What's the fuzzy stuff? That is, this stuff here is the annulus fibrosus. This white strands right at the tip is called the posterior longitudinal ligament. The yellow stuff is fat, like a little bit of fat. The red stuff are blood vessels. I just zapped one. And yeah, that's all posterior ligament right there. So this is annulus that's scarred. We're in the back of the disc, the back corner on the right side, right now. There's the tear. Cleaned up. I'll show you the nerve root again. Standby laser, we're done. All right, check out the nerve root. Let's see. No, we don't get to see it so well this time. So last one was very visible. Let me get that tear down there. Need one more minute. So we saw the nerve root really good at the L5 nerve root, L5S1. Let's go back and look at it. But here the nerve is just buried in fat at the top half of the foramen. So we're not going to see it. All right, good. Done. Done, done, done. Type your questions up. I will come and answer your questions live. Scope off. Nice work, everyone. I'm going to show you guys, those that are watching, I'm going to show you this incision in just a second. Yeah. You're doing great. Hey. You're fine. Actually, I think it works just pushing through the holes. Yeah, look, clean it up. You know what I'm thinking? I'm thinking just a little short needle, even a blunt tip that goes in the hole, just short, and I flush it through the dilator. Okay, so you're all done. Our patient's waking up. We're going to take this little tube out, and we're going to apply pressure to the incision. You're done. You did it. I'm just putting pressure, okay? That's me pushing down. It's nothing to be afraid of. Just relax. We're going to have you out of here in a minute, okay? Your surgery went perfect. You're welcome. My pleasure. That's what we do. We strive for perfection. Okay, there's the incision right there. You all see that? And the whole surgery was done with one little cut, Band-Aid, and he's going to go home in an hour. Hey, how is my other patient doing? Hello? How's our last patient doing? Ready to go? All right, let me go check on him. You got this? I would do one, right? So you go deep, come out through the dermis halfway, and then go in halfway in the other dermis and deep, so you bury the knot. All right, I'm going to go check on the last patient and get him out of here because he's been waiting for me to go home. I like to check on my patients before they leave. And then we're going to do our last surgery. The last one's a 1 level? What level is it? Do you all know? Oh, good. 4-5. Easy one. I shouldn't be happy about it being easy, but you know what? Hey, why not? So it probably won't be easy. I probably jinxed myself, I'm sure.
If you have the means to do this, you should do it because it's life-changing. Thank you.
You're welcome. I'll see you out there on the go-kart track. Say to the rest of the world before we wrap this interview up?
If you're thinking about it, come see Dr. Deuk. I've been telling everybody, come see Dr. Deuk. You changed my life.
I'm so happy for you. Take care.
come see him.
Oh, thank you very much.
Take care. Anything else you want to say to the audience before you get out of here and go home?
It's a good place to come and get answers.
Absolutely.
Anything you want to say?
He's worked on both of us, and we can't say enough to thank him enough for his expertise and willingness to do things that other doctors would not do, wouldn't take even the risk at doing. He's able to do that is beyond our comprehension, and we are very grateful and thankful for Dr. Deuk.
Duke Spine Institute is grateful for both of you. So thank you.
Thank you.
You're welcome.
are ready.
Always a countdown.
3, 2, 1. Okay, cool. Now you're live.
Dr. Deukmedjian here, and just wrapping up a Deuk laser disc repair surgery. And the Deuk laser disc repair surgery is basically a type of endoscopic spine surgery. And if you think about the spine three-dimensionally, you have the back, you have the front, you have the sides, okay? So the back looks like that. This is the way most spine surgeons approach the spine. And what do you notice is that you can't get to the disc because there's bone here. So to get to the disc, which is there, you literally have to remove bone. And that's what surgeons do. All of the spine surgeons that do laminectomies, microdiscectomies, fusions, they all have to take bone out of your spine to get to the disc. However, what we do is we come from the side like this. That's our approach. So we're coming in, we're not removing any bone or ligaments from the spine, and we go straight into the herniation there. That's the disc right there. And we get into the disc right where the herniation is, right where the nerve is, right where the tear is that's causing all the back pain. So we actually land in the most perfect spot, and we get there without doing any damage to your body. There's no bleeding, there's no scar tissue, you saw the surgery, all right, a couple of drops of blood. But it's the most amazing surgery. It's done with the least invasive approach to the spine. There's no damage to your body whatsoever except for a little cut on your back. So our patient we just finished up, he had 2 painful discs, L4-5, L5S1, with big tears, lots of scar tissue from inflammation. I cleaned it all out with the laser. Surgery went perfect. And I'm here to answer your questions. And what's our first question?
We have a question from Facebook. He says he is experiencing numbness in his right leg and tingling. He wants to know, if you, based on your knowledge, what it could be.
Yeah, so somebody has numbness and tingling in their right leg. So the number one diagnosis, the most likely cause is going to be a herniated disc. And we're going to run a video in a minute. Diego's going to run the video. It's going to show you why a herniated disc causes back and leg pain. The second most likely cause, and this is about 10% of the time, is going to be a piriformis syndrome. And that's where there's a muscle that's torn in the buttock, piriformis muscle. Patient would have a lot of pain in their top of their buttock, on the side of the sciatica, and it would be tender. So if you push on your butt cheek, it would be really sore. And you may even feel the pain shooting down your leg. That's called piriformis syndrome. P-I-R-I-F-O-R.
The laser removes the herniation and debrides the
Those
annular
are really
tear.
the 2 most common causes, with the herniated disc being 90% of the
The
time.
annular tear heals on
and
its own.
the piriformis syndrome being almost 10% of the time.
Okay, cool. I also have the article if you want to talk about it.
Yeah, and we do have an article. I'm going to do
If you have a
reaction
herniated or
video
bulging
on,
disc and back
YouTube.
pain,
But
submit your
basically,
MRI
can they
for a
see
free
the actual
review
article?
at www.mri.deukspine.com.
It's linked also.
Disc herniations are a common cause
Well,
of chronic
again,
back
I
pain.
mentioned this earlier, but look, there's people trust their spine surgeons, and sometimes you can't, because spine surgeons, unfortunately, and this article
The
highlights
inflamed
it,
annular tear
went around
causes
the
back
news
pain.
today around the country. There's a group of spine surgeons
Inflammation
that
of
were
the
getting
nerve
paid off
roots
to put
causes
these
leg pain.
expensive implants in people's spines. Just to give you an idea of how
A
much money
Band-Aid
is in
sized
these
skin
implants,
incision is
this is
made.
a 1-level lumbar fusion. Each screw runs about $1,000. The rods here are about
A small tube is
$200 to
inserted
$400.
without damaging the bone
And
or soft
the cage right
tissues.
here, they charge about $4,000 to $5,000 for that cage. So, and then there's set screws, little screws that lock the rod in. This whole thing, screws and rods and
The
cage
laser
for one
removes the
level fusion
herniation
or
and
back,
debrides the
you're
annular
looking
tear.
at anywhere between $8,000 to $12,000.
The
in
annular
metal.
tear heals on its
And
own.
the companies that sell these implants, well, they're so greedy. They don't want you to know about the Deuk laser disc repair endoscopic surgery that doesn't use metal. They
If
don't
you have a
want people to know
herniated or
about it
bulging
because they don't want
disc
people
and
to get
back
it.
pain, submit your
Because when you
MRI
look
for
at
a
the
free
results of
review
the Deuk
at
laser disc repair versus fusion, it's a no-brainer. You
www.deukspine.com.
want the laser surgery
Disc
because it
herniations are
works
a common
better than
cause of
fusion.
chronic back pain.
There's no complications, and you recover overnight, whereas fusion surgery, you're laid up in bed for weeks. So would you want a fusion done on your spine, or would you rather have a small
The
incision
inflamed
and the disc
annular
repair
tear
with
causes
laser?
back pain.
The answer is laser. If you know anything about
Inflammation
getting
of the
your back
nerve
fixed,
roots
if you've
causes
done some
leg pain.
research, 100 out of 100 people would choose
A Band-Aid
endoscopic
sized
laser
skin
surgery.
incision is made.
But surgeons don't give their patients that choice. Why? Because they're getting paid.
A small
to put
tube is
these
inserted
screws and
without
rods in
damaging
you,
the bone or
and
soft.
they're getting kickbacks that are illegal. Not all of them are getting paid kickbacks, but many of them are. As a matter of fact, the companies that manufacture and sell these screws and rods, they know who the busy surgeons are. They keep track of it. They've approached me many times. They know that I'm very busy. There's an old saying, 10% of the surgeons do 90% of the surgery. So they target those 10% of surgeons that do spine surgery, and they want those surgeons to use their screws and rods and cages and plates. And they give them kickbacks, and that's exactly what that story is about. It's pretty self-explanatory. All right, I enjoyed our time together. Have a wonderful day. We have one more surgery
Disc
coming up
herniations
in
are a
about
common
30
cause of
minutes.
chronic. Traumatic injury to the disc can cause annular tears to form. Pressure on the disc causes herniation of the nucleus pulpus through the annular tear. Inflammatory tissues develop within the annular tear, causing back pain. The inflamed annular tear generates pain signals. Additional injuries can cause symptoms to worsen. Inflammation from the annular tear can spread to nearby nerve roots, causing leg pain. Signals travel up nerves to the brain, causing localized back pain. Pain signals reach the primary somatosensory cortex, causing conscious awareness of pain. If you have a herniated or bulging disc,